Ladies and gentlemen, we are going to introducing you the colorectal cancer screening in 2021 based on ACG guideline. And I'm Dr. Wei-Yu Chen, Division of Colorectal Surgery in Changhua Christian Hospital. In the United States, colorectal cancer ranks second to lung cancer as a cause of cancer mortality and is the third most commonly occurring cancer in both men and women. A study estimated that in 2020, approximately 150,000 new CRC cases would have been diagnosed, and around 50,000 individuals had died of this disease. Between 2011 and 2015, the average annual incidence rates per 100,000 population were 45.9 and 34.6 for men and women, respectively. CRC incidence and mortality rates have shown a steady decline of approximately 1.7% and 3.2%, respectively, per year. The decline began in the mid-1980s and has accelerated since the early 2000s. It's believed to be driven by changes in risk factors, early detection of cancer through CRC screening, and removal of pancreas polyps with colonoscopy, in addition to advance in surgical and treatment approaches. Most CRCs develop through the adenoma-carcinoma sequence, presenting opportunities to prevent cancer by removing its precursor lesions, in addition to identifying CRC in its earliest curable stages. Approximately 17% of sporadic CRC develops from adenomatous polyps, and 25% to 30% arise from sessile serratus lesions through the SSL to carcinoma pathway. CRC screening efforts are directed toward removal of adenomas, sessile serratus lesions, and the detection of early-stage CRC. Certain screening modalities such as colonoscopy, sigmoidoscopy, CT colonography, and to a laser extent stool-based testing will detect advanced adenomatous polyps, whereas colonoscopy is optimal for the detection of the SSLs. Endoscopy removal of polyps reduces CRC incidence and CRC mortality. Given new evidence regarding enhancing screening adherence, newer methods for CRC screening, and evidence to support the efficiency of screening. The purpose of this article is to update the 2009 American College of Gastroenterology CRC screening guideline. So it's very important for us to understand who is at risk for colorectal cancer. As above, we can see people who have family history of colorectal cancer, family history of adenomas, cigarette smoking, obesity, gallbladder removal, physical inactivity, abdominal radiation, cancer of the uterus or ovaries before 50 years old, ulcerative colitis or Crohn's disease. African American races are at risks for colorectal cancer. So knowing who should receive screening colorectal cancer is very important to prevent CRC. The ideal screening test should be non-invasive, have high sensitivity and specificity, be safe, readily available, convenient, and inexpensive. For CRC screening, there are multiple approved tests and strategies, each with its strengths and weaknesses. In some instances, the best screening test can be considered the one that is acceptable to the patient and gets completed. One approach to CRC screening test is to divide them as one-step tests, such as colonoscopy, which is diagnostic and therapeutic, or two-step tests that require colonoscopy if positive to complete the screening process. All screening tests other than colonoscopy are two-step tests. A major limitation of non-colonoscopy-based CRC screening tests, such as stool-based flexible sigmoidoscopy, CT colonography, or colon capture, is that a positive test requires a follow-up colonoscopy. This two-step testing approach represents a continuum of screening, requires strong system-based support to complete the screen cassette, and is more effective applied in organized screening. In the United States, there are few select healthcare systems which organized program screening, and most screening is accomplished with a one-step opportunities approaches. Because the focus of the guideline is on providers practicing in the United States, the review highlights options of CRC screening currently in use, which mainly include colonoscopy and is an organized setting. Fecal immunochemical test, FIT, or two-step tests such as flexible sigmoidoscopy, multi-target stool DNA tests, CTC and CC, are reserved for individuals unwilling or unable to undergo colonoscopy or FIT, or those with incomplete colonoscopy. Comparative effectiveness studies are lacking. And now we are going to discuss a one-step screen test. Colonoscopy is the most commonly performed gastrointestinal procedure in the United States. It allows for not only the detection of early-stage cancers, but also the detection and removal of polyps, and confers a long-term protection from CRC incidence and mortality. A systemic review of 6 observational studies report a pool reduction of 69% in overall CRC incidence and a reduction of 68% in CRC mortalities associated with screened colonoscopy. In a case control study among US veterans, reported reduction in CRC mortality of 17% with screened colonoscopy, including a 52% reduction in proximally CRC mortality in veterans exposed to screened colonoscopy. It was reported a reduction of 91% in CRC incidence, including a 78% reduction in proximal CRC incidence in a German population-based study of screened colonoscopy. And compared with the flexible sigmoidoscopy, flexible sigmoidoscopy allows direct evaluation of the left side of the colon, and if adenomatosis are found, referral for colonoscopy is required. For large randomized trials of flexible sigmoidoscopic screening, the comparable 10 to 30 years of follow-up have been published. 2 trials from the UK and Italy offer once-only flexible sigmoidoscopy examination to participants aged from 55 to 64 years, and reported a reduction in CRC incidence by 23% and 18%, and CRC mortality by 31% and 22% respectively. The US trial, which include participants aged from 55 to 74 years old and over flexible sigmoidoscopy screen every 3 to 5 years, reported that CRC incidence was reduced by 21% and CRC mortality by 26%. A recent study of pooled flexible sigmoidoscopy trials reported no reduction in CRC incidence or mortality in women 60 or older. Rates of screening flexible sigmoidoscopy have declined in the United States of the following reasons. The infrastructure needed is similar to that of colonoscopy. It does not extend the entire colon. It requires colonoscopy for those with adenoma findings, and the lack of sedation makes the procedure uncomfortable. Given recent evidence of lower effectiveness in women and the practical issues with scheduling and availability, flexible sigmoidoscopy should be considered a screen test for individuals unwilling to undergo colonoscopy or FIT. And when it comes to two-step approach screen tests, 3 large RCTs with 11 to 30 years of follow-up were conducted in Europe and the United States. These trials randomized average risk individuals between age from 45 to 80 years to annual and biannual screen using guaic fecal occult blood testing, GFOBT, compared with usual care. With biannual screening, After 13, 20, and 30 years of follow-up, there was a corresponding 80% reduction in CRC mortality. With annual FOBT screening, there was a sustained 33% reduction in CRC mortality over 30 years. There have been many advances in stool-based tests for CRC screening. GFOBT have been largely replaced by FIT, which has highly sensitivity for CRC. The FIT sampling technique is easier as many tests require a single fecal sample, and it has higher adherence than GFOBT because no dietary modification or medication restrictions are required. Both quantitative and quality FIT are commercially available, with the option to set thresholds for the detection for quantitative tests based on population risk. Studies have shown that FIT has greater sensitivity for detecting CRC and advanced adenomas than both standard and highly sensitivity FOBT with comparable specificity. It must be emphasized that a positive FIT requires a follow-up colonoscopy and quality assurance programs to ensure that colonoscopy is performed. Rates of diagnostic colonoscopy for the evaluation of a positive stool test are suboptimal and require improvement in both programmatic and particularly opportunistic screening. Recent systematic review and meta-analysis have reported a relative reduction in CRC mortality of 12% over 15 years the biennial fecal-based testing, compared with no screening. In recent guidance, the ACG, American College of Physicians, also suggests biennial fecal-based stool testing as an option compared to colonoscopy every 10 years. However, given the large effect estimate of annual FOBT in clinical trials and the effectiveness of annual FIT CRC screen programs, annual testing is the preferred interval. The multi-target stool test, MTS-DNA test, is an FDA-approved stool test that comprises an assay for mutant KRAS, methylated BMP3, methylated NDRG4, and a FIT for hemoglobin. The specificity of the MTS-DNA test decreases with advancing patient age. In two recent modeling studies, annual FIT and colonoscopy every 10 years were found to be more effective and less costly than MTS-DNA testing every 3 years. Based on the current available data, we recommend that asymptomatic individuals with a positive MTS-DNA test and a negative high-quality colonoscopy not undergo additional testing, such as upper endoscopy, CT of the abdomen, or repeat colonoscopy at an interval shorter than the recommended repeat screen interval, unless detected by other symptoms or laboratory testing. If the MTS-DNA test is negative, the interval or repeat MTS-DNA test or transition to another screen test is 3 years as per manufacturer recommendation. Longitudinal studies on outcomes after the MTS-DNA test and optimal repeat intervals were awaited. Alternative imaging tests for individuals who refuse colonoscopy or FIT or are not candidates for colonoscopy. CTC and CC are two non-endoscopic screen tests in this category. The diagnostic accuracy of CTC in average risk screens has been assessed in multiple studies. The sensitivity ranges between 68% to 98% for lesions more than 6 mm and 67% to 94% for lesions more than 10 mm. Whereas specificity ranges from 80% to 93% for lesions more than 6 mm and 86% to 98% for lesions more than 10 mm. However, the diagnostic accuracy of CTC for the SSLS is significantly lower than that of colonoscopy. There also remain concerns for detection of right side and flat polyps and operator dependence. test characteristics of CC have been improving because of enhancement to software and hardware. In a prospective study of 884 average risk individuals due to screening, 79% of CC could be completed, and the sensitivity to detect adenoma more than 6 mm was 81%, and the specificity was 93%. For polyps more than 10 mm, the sensitivity and the specificity were 80% and 97% respectively. At this time, CDC and CC are options for individuals unable to undergo colonoscopy or FIT, provided that the tests are locally available and reimbursed for the instance of screening. It is important to note that both tests require a follow-up diagnostic colonoscopy if the result is positive. CRC screening is average risk individuals starting at age 45 years old. Recent studies have highlighted a rising incidence of CRC individuals younger than 50 years old in the United States. Although CRC incidence has continued to decline in those aged in 50 years and older, the incidence rates have doubled in 20 to 49 years old. In 2018, the American Cancer Society published guidelines with a qualified recommendation to lower the starting age of CRC screening from 50 years old to 45 years old in the average risk adult population. Even through the current recommendations of the U.S. Prevention Service Task Forces and the multi-specialty task forces are to begin screening at the age 15 years. These qualified recommendations were based on predictive modeling analysis and age cohort epidemiological evidence of a relative increase of 51% in CRC incidence among individuals younger than 15 years between 1974 and 2013. Modeling studies using two of the three cancer intervention and surveillance network models found that initiation screening at age 45 years was won the efficiency spectrum, and that initiation screening at age 45 years instead of age 50 years would result in approximately 25 more life years gained per 1,000 individuals screened. Recent epidemiological data showed alarming trend reversals for CRC incidence in the United States, notably CRC incidence among individuals aged from 50 to 64 years, which had historically declined by 2% to 3% per year, has increased by 1% annually between 2011 and 2016. A similar increase in the incidence rate is observed in individuals younger than 15 years and has been thought ascribably to a birth cohort effect, in which increased CRC risk in individuals born after 1950s is carried forward as they age. It has been estimated that persons born around 1990s have twice the risk of colon cancer and 4 times the risk of rectal cancer compared with those born around 1950. Although the reasons for this observation are complex and multifactorial, the fact and other development countries are reporting similar increase in early onset CRC and birth cohort effects such as the Western lifestyle is a significant contributor. An advantage of initiation screening at age 45 years instead of 15 years include reduced CRC risk due to early detection of CRC in this age group. Overtime detection and removal of polyps in individuals aged from 45 to 49 years would reduce the incidence of CRC in those aged in 15 years and older. In addition, preventing young CRC is a desirable goal because the society impact of CRC deaths at an early age is particularly devastating. CRC screening in elder individuals with gains in life expectancy and increase in the geriatric population. CRC screening in the elderly has substantial public health consequences. Because few detailed subgroup analyses of screening trials have been reported, few empirical data exist on when best to stop ovarian screening. There are several reasons why the elderly may not derive the same benefit or may even be harmed by screening. The first reason is diminished life expectancy. The benefits of polypectomy are delayed by 7 to 10 years after screening has occurred. And the last, screening is of limited benefit for those not expected to live for at least a future 7 to 10 years. Second, there is an increase in competing cause of death in the elderly. The value of screening decreases as the risk of dying of other causes increases. Hence, for the elderly, the benefit may become small enough to be negligible or even negative impact their life expectancy. Third, live individuals may be more susceptible to risk associated with undergoing screening compared with the younger counterparts. In older people, the benefit of early detection and prevention of CRC may be offset by higher risk of procedure-related harm and diminished health and life expectancy. The most recent guidelines on CRC screening from the USPSTF concluded that in adults aged from 76 to 85 years, the decision to screen for CRC should be individualized, taking into account the patient's overall health and the screening history. The guidelines specified that screening would be most appropriate for those not previously screened, those healthy enough to undergo treatment if CRC is detected, and those without substantially limited life expectancy. In adult age more than 86 years and above, screening is not recommended because of competing cause of mortality. The guideline identified when to stop screening as an important area of future research. Although further studies are awaited, providers should consider life expectancy, patient risk values, and prefers and participate in shared decision making for screening individuals older than 75 years. So here are the recommendations of screening methods as above. We recommend the following tests as the primary screening methods for patients at average risk for colorectal cancer on this schedule. First, colonoscopy every 10 years. Second, FIT every 1 year. And if one of these alternatives is used, we suggest that the test be done on this schedule. First, mTS-DNA test every 3 years. Flexible sigmoid every 5 to 10 years. Third, CT colonography every 5 years. Fourth, colon capsule every 5 years. We suggest against blood-based test for colorectal cancer screening. When it comes to screening for African Americans, boosting CRC screening rates in African Americans have among the highest rates of CRC of any racial ethical groups in the United States. Compared with whites, incidence rates are 24% higher in African American men and 90% higher in African American women. Stage-adjusted CRC mortality is also disproportionately higher in African Americans, with rates being 47% higher in African American men and 30% higher in African American women compared with whites. The reason for these differences are not entirely clear, but disparities in care such as lower rates of screening, diagnostic follow-up, and treatment postulated. Based on recent SEER data, modeling studies show similar benefit of CRC screening in African Americans and white starting at age 45 years. Special efforts and outreach programs are needed to boost screen in African Americans to reduce the disparities in the screen rates and reduce incidence rates. So there is no excuse that we have to get screened for colorectal cancer. Despite the availability of multiple screen modalities and the various public health initiatives or boost a CRC screen, nearly 1/3 of the eligible US population is unscreened. CRC screen rates must be optimized to reach the aspirational target of 18%. Substantial reductions can be made by achieving high rates of adherence and providing fail-safe systems to decrease barriers through the spectrum of care from a positive non-colonoscopy test to colonoscopy to complete the screening process. Acknowledge the available screening tools for use in the correct setting of each population will increase the compliance of different populations. Consistent with these goals, adoption of cost-effective, highly accurate, non-invasive methodologies associated with reduced complications and barriers than more invasive methods may improve overall acceptance of the screening process. FIT is a widely accepted and cost-effective, non-invasive two-step CRC test and is optimal for programmatic screen and when systems are in place to navigate patients into colonoscopy. Colonoscopy is a one-step CRC screen test, the final common pathway for a positive non-colonoscopy screen test and most appropriate screen test for individuals with a family history of CRC. The quality of provision of CRC screen by any method must be monitored and improved to achieve the reductions in CRC incidence and mortality. And thank you for your listening.